This week on the BackTable podcast.
And I said, what do you mean? We can't give ketamine, and don't you need to get anesthesia?
Yeah.
And she's like, no, we do it all the time in the ER. I was like, well, why ketamine? And then she explained. So ketamine is, as it turns out, a procedural wonder drug. So number one, obviously it kind of gets you exactly what you want for your patient, which is they're still, they don't talk, they don't remember anything. And it also has these effects on making you happier and have less chronic pain. So everybody leaves with a smile on their face. The other really great thing about ketamine is it does not depress your breathing. Unlike opiates, it preserves your respiratory reflexes and it does not lower blood pressure. So think about the cancer patient who their blood pressure is so low you can't really give them two agents, and then they're suffering in their palliative drainage procedure, for example. So ketamine has been this huge game changer for me in enabling me to provide every patient with a good experience.
Welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a quick word from our sponsor.
Trying is believing. Nothing compares to trying a device in your own procedures and with your own patients. That's why we invite you to experience the Abre venous stent and see what makes it different. Learn more about Abre at medtronic.com/Abre stent.
Now, back to the show. Today, my guest is Dr. Amy Deipolyi. She's an associate professor and division chief at Charleston Area Medical Center in Charleston, West Virginia. Amy, thank you so much for being on the show.
Thank you so much for having me.
Our topic today is going to be deep sedation for IR procedures, something I'm pretty interested in, and I think a lot of my colleagues are. So thanks for reaching out and being able to talk about this. I just want to start with a little bit of background information. Can you tell me a little bit about what your practice is like today?
So I started in West Virginia 3 years ago. I'd never been here before coming for the job. Before that, I was working in New York City for 7 years, most recently at Sloan Kettering in interventional oncology. And I came down here because of a job opportunity. So I work at the Charleston Area Medical Center, which is in the state capital. It's a 1,000-bed facility that has a level 1 trauma center, stroke center, and a cancer center, and serves the bottom half of West Virginia. And despite being such a big center, they never really had a dedicated IR program, freestanding. So I basically came here to start one up. So at first I worked in the vascular surgery division, sort of in a Miami Vascular type setting with a multidisciplinary vascular group. But ultimately the need was so big for IR specifically that it sort of has broken off and moved down into radiology, where we mostly focus on interventional oncology and portal intervention because the vascular surgeons do such a good job covering PAD and aorta and kind of your more typical vascular surgery procedures. But we have a good collaborative relationship, but we just really have a lot of work to be done in this facility.
Help me understand, is it like a totally private facility? Is it private-demic? Is it totally academic?
That's a great question. So CMC was traditionally private practice, but has been transitioning into an academic center. So it's an academic center in its own right. We have residents and fellows in all different specialties. But it also has an affiliation with WVU. So WVU Med School is kind of centered in Morgantown, which that facility serves the top half of the state, but about half their medical students come down here for their clinical rotations. So it's sort of a hybrid model, and over time, more of the physicians are becoming either CMC employed or having an affiliation with WVU. So it's sort of a mix of some private practice, but academics too. And they also created the Institute of Academic Medicine, which supports academic pursuits like trials and such.
Okay, yeah. So when you started out 3 years ago, you were the first interventional radiologist there. Is that right?
There was an interventional radiologist who worked here several years ago, Laura Findus. She was the president of SIR 1 year. And she said it was the greatest job she ever had.
Wow.
She was essentially, she was an IR physician that was essentially a vascular IR physician that would do some embolization procedures, but did PAD and such like alongside the other vascular surgeons. when I got here, there was a lot of the non-vascular work to be done. So I ended up, starting ablation programs, complex drainages, brought Y90 for the first time here. So we have Y90 TACE, everything
So awesome.
available,
Yeah.
kind of de novo. Yeah.
Man, are you still the only IR doctor there, or have you hired some colleagues?
So I was able to steal a colleague, Mike Corona, from Huntington, West Virginia. That's about an hour away from here. He's been in practice for more than 30 years, and so I was able to recruit him. I think they wanted him in the past, but people have always been reluctant to come here because there wasn't a dedicated IR program. And now that there is one, he came, and we're about to hopefully hire a third person. Before I got here, there weren't any dedicated facilities, and now we have a 3-room procedural area with a 6-bay perioperative recovery suite. And we have a team of over about 20 to 30 people, including APPs. We do a full clinic, everything that a modern academic IR program would do.
That is so neat, man. And it's kind of like you left like this hub of industry and development and cutting edge stuff at Sloan Kettering, and basically we were able to kind of like build this program to be exactly what you wanted. But yeah, I'm sure that definitely came with some challenges as well. What would you say was, like, looking back now, 3 years ago, what would you say was like the biggest thing that you didn't expect when you moved to West Virginia from New York City?
So I knew I was going to build a program. I looked at all the equipment and I knew I could kind of patch together what I needed to do things like Y90 and such. The only thing the only 2 things I asked for were an ultrasound machine, which they gave me no problem, and an APP. Those are the 2, and they gave me both those things. But now fast forward 3 years, and I've obviously gone through a huge process of learning about some of the fundamentals that an IR program needs. Beyond that, I mean, even down to the level of, we use Cerner for our medical chart. We don't have Epic. We had to create hundreds of procedure-specific orders to be able to schedule cases and then document them and for billing. So just a lot of infrastructure and things that I guess I just took for granted, having come from big organizations. And so I guess part of the both joy and challenge of the job has been kind of figuring out every inch of what would be needed to create a program like this. So
wow.
And I will say on the other end of it, what's really inspiring about this job is that because they didn't have IR before, all of the patients and physicians in the community are so appreciative of what we do. So every day there's someone just saying thank you. And that's just such a blessing, because in my last practice, I think there were like 25 IR physicians in the group, which is certainly wonderful because everyone can subspecialize and there's not as much call. But, I think you can kind of be taken for granted more. And here, there's just a lot of appreciation. That's very rewarding.
Amazing. I did not know any of that about you, but I totally respect you greatly after hearing that part of that story. Well, let's kind of move on to the topic at hand, which is procedural sedation. So I guess, most IR procedures, when we do sedation, we kind of just do fentanyl and Versed. So is that what you started with when you started your program a few years back?
Yeah, I think ever since I finished fellowship back in 2013, 2014, that's what you do. You do fentanyl Versed, and then for things that are, more invasive or the patient can't tolerate it, then you try to get anesthesia to come help. So we're blessed that we have dedicated anesthesia time 3 days a week, which is really wonderful. But, it's not going to cover necessarily all the needs. The other issue here in West Virginia is this is one of the centers of the opiate crisis. There's a lot of people who are not naive to opiates, and so they really are not sedatable with fentanyl Versed. So when you're looking at even just simple 10-minute procedures, fentanyl Versed, or isn't going to cut it, and you're going to have to get anesthesia, which adds time to the case and complication, and just trying to get the help and difficulty in scheduling.
So how did you come upon these advanced anesthesia techniques, or decide that they were right for your practice?
So I guess this story about my relationship with sedation starts back during my residency. I had this case that I still clearly remember where we were doing a biliary drainage in a 52-year-old Spanish-speaking lady, and we couldn't get anesthesia. And we tried it with moderate sedation, and we were giving the maximum amounts of everything and kind of struggling with the drainage. And she was screaming in Spanish, kill me, this is awful, like just terrible things. She obviously suffered. She was cholangitic. We had to get the case done, but, we just really, it was just a very memorable moment and, an unpleasant moment. And I remember after the case, my attending said to me, you're going to have to toughen up if you're going to be an interventional radiologist.
Wow.
You have to kind of put those feelings aside so you can focus on what you're doing.
Well, but honestly, that sounds like you should have just been able to get anesthesia. Like you shouldn't have to feel like you're injuring somebody, right, when you're doing a case. And sorry to interject, but yeah. So,
no, I think you're right. Like, number one, in an ideal world, like every case would be done with anesthesia. Kind of like, in the old times or like years ago, GI would do colonoscopies and such with moderate sedation. But now I think modern days, as a patient, I just assume I'm going to get propofol and be asleep and not know anything about my procedure. And so I think most other specialties have really transitioned. And IR is kind of the last type of medicine where we still have a heavy reliance on moderate sedation. And I think the reasons for that are practical. We just have such a high volume of cases, and the cases are very short. So we're operating under this kind of model about what we do traditionally, but patients expect to be asleep. I mean, how many times in your practice, even if you've said it until you're blue that you're not going to be asleep, it's a twilight, et cetera, that they still have this perception that they should be asleep. And so, I think looking at those patient experiences, those sat with me. My partner calls them moral injuries. Like when you cause someone to suffer, unnecessarily, it isn't enough to do a life-saving procedure or a life-changing procedure, whatever procedure that the patient needs. They need to have a good experience and not look back on that experience with horror. So I had, one of these types of experiences a few months ago at my current job. I think it was like a tube ovarian abscess or something that we drained. Patient was kind of screaming, and we got them through. And I was out to wine with one of my colleagues from the ER, and she said, well, why don't you just give ketamine? And I said, what do you mean? We can't give ketamine, and don't you need to get anesthesia?
Yeah.
And she's like, no, we do it all the time in the ER. And I just kind of had this light bulb moment where I'm like, you do like deep sedation without anesthesia? I thought you had to get them. But remember, like, not just them, think about dentists. Dentists are giving laughing gas, right? So there are all kinds of doctors who are not anesthesiologists who are doing deep sedation out there. It's just that we're so busy and we have such a high volume of cases, we just don't even think about it, I think. So I was like, well, why ketamine? And then she explained. So ketamine is, as it turns out, a procedural wonder drug. So number one, obviously it kind of gets you exactly what you want for your patient, which is they're still, they don't talk, they don't remember anything. And it also has these effects on making you happier and have less chronic pain. So everybody leaves with a smile on their face. The other really great thing about ketamine is it does not depress your breathing. Unlike opiates, it preserves your respiratory reflexes and it does not lower blood pressure. So think about the cancer patient who their blood pressure is so low you can't really give them 2 agents, and then they're suffering in their, palliative drainage procedure, for example. So ketamine has been this huge game changer for me in enabling me to provide every patient with a good experience.
Okay. And so then you just kind of went to your lab the next day and you were like, I want some ketamine. No, I'm sure you didn't do that. But tell me how you got administration to be on board with this, because I feel like that would probably be the biggest hurdle at most institutions.
Yeah. I'll say that here in this practice, we're blessed. There's a very strong community of physicians. We're in the state capital of the population of something like 40,000. So everybody kind of knows each other. And all your kids are in the same program. So there's a strong kind of community of supportive fellow physicians. So I'll start with that. And the anesthesia doctors are, especially very good. So We have a sedation committee, and I'm sure most hospitals has a sedation committee. And it is, the chairperson is a anesthesiologist, and then there are several ER physicians on that committee too. So the first step was to directly reach out to the committee chair and a couple of the other members of the committee and just kind of talk to them. And it turned out that they were incredibly supportive. They realized, number one, there's a shortage of anesthesia providers. There's not enough attendings and there's not enough CRNAs. I'm sure other places have struggled with this, and we have struggled with it. And so there simply are not enough anesthesia providers to do monitored anesthesia care or general anesthesia for every patient that comes through IR. So there's a recognition of that. And then number two, those individuals had experience with deep sedation with ketamine and knew how safe it was. So, every hospital will have a sedation policy, and that policy is written by probably with the, help of a sedation committee. So I lobbied to the committee, I made a presentation about it, and then they voted to essentially change some of the verbiage, which was just to add the interventional radiology procedure area as a place where it's allowed to be performed.
Cool.
The institution that you work at will already have a policy enabling the ER physicians to do it. So you just will end up mimicking it for your area. And then an ER doctor and an anesthesiologist proctored us on a few cases. And then we got our privileges granted and we were ready to go.
Oh, man. Okay, cool. Well, did you face any pushback from the committee about it's not safe for IR doctors to do this or anything like that? Or was it pretty much just that makes sense. Why don't we do this for other interventional specialties?
Let's see. The first thing that they needed to do was to look at the ASA guidelines. So when I at first presented, it wasn't an immediate hooray, this is going to be great, let's do it. They did their own research, which mostly involved looking at literature and looking at ASA guidelines before changing the policy. That was the first thing. Number two, I have a wonderful nurse manager. Her name's Caitlin, who oversees the IR area. And I think, any time you're bringing something new to a group, there's going to be a little bit of nervousness about bringing a new program on. So I think something that we feel very comfortable about with fentanyl and Versed is that we have reversal agents. So we have this perception that we can easily just undo the sedation we did, whereas ketamine does not have a reversal agent for it specifically. I mean, there's still flumazenil for the Versed that you would give with it, but not for ketamine. And so I think people were a little anxious about that. However, once you start gaining experience with it, you quickly see how much better it is than moderate sedation, and kind of those fears go away. And that's just the expectation on our unit now, and people are just very comfortable with it. And in fact, we did a prospective quality improvement sort of project where we collected patient pain scores before and after bringing on deep sedation and compared them. And we also did staff surveys and asked them what they thought about deep versus moderate sedation. And one of the final questions was, what kind of sedation would you want for yourself if you were having, say, an abscess drainage? And 90% say deep sedation. I think that speaks strongly to that. And the final kind of area of a little bit of pushback was, in trying to get someone to proctor us, everybody's very busy. So you'll have to get someone who's willing to kind of come on their time when they're not already busy with their clinical work or administrative work. And I remember asking some of the anesthesiologists who weren't on the committee to maybe proctor, and they were kind of opposed, and they said that they would never use that regimen, so why would they proctor doing that? And so, I think there's a little bit of bias in the anesthesia sort of community against just ketamine sedation in and of itself.
I see. Okay. I don't know much about that, but what are the concerns with it? What do they not like about it?
Honestly, I think that they have so much variety in what they can choose that and that's their focus, right? Their number one focus is sedation, anesthesia. They're not thinking about doing it as an adjunct to a procedure. So the number one reason for me that I like it is that it's deep sedation without worrying about the breathing. So it makes it very safe that I don't have to worry about getting into a respiratory issue. Ketamine does cause emergence reactions sometimes where patients may have hallucinations and such. So perhaps that's why they try to get away from it. But, we always administer it after giving Versed or midazolam, and that kind of eases the the sedation and really minimizes the emergence phenomena.
So I guess let's get into a little bit of the nuts and bolts of how you do it, since we started talking about it. Okay, so patient comes into the procedure room, you do your timeout. What do you do after that?
So the first thing, you need to make sure they don't have really high blood pressure, because ketamine will bring up the systolic pressure by 20. So if the blood pressure is borderline high, say above 180, 190, I'll usually give hydralazine to try to get that blood pressure under control. Once we have a reasonable blood pressure, I almost always give 2 of Versed. For people who are, more frail, really elderly, we might just do 1. And then you wait about 5 minutes, and then you give a bolus of a low-dose ketamine, which is usually about 30 milligrams. If the patient has had a long history of drug exposure, such as an opiate user or a cancer patient who's on pain meds, that bolus may go up to 50 milligrams initially. And then we proceed with the procedure. All the medications are given IV. And if the procedure is longer than about 15 minutes, then you may have to give a PRN dose, and those are usually 10 or 20 milligrams each. The maximum dose we'll do, usually we do not exceed something like 100 milligrams. It's 1 to 2 milligrams per kilogram is kind of your maximum dose for deep sedation.
I see. Are there any other patients that you don't think that ketamine is appropriate for, and you would just kind of go straight to general anesthesia?
So any patient where high blood pressure is a serious concern, like aortic stenosis, I wouldn't use it for a renal biopsy because we always worry about the blood pressure and keeping it low for that. Those are the main contraindications. Also schizophrenia, because of the emergence phenomena, may synergize with a psychiatric condition.
But yeah, otherwise it seems like it's good for the majority of your patients. So this is what you do now instead of fentanyl and Versed. So you're not really given fentanyl during the procedure at all, huh?
No, I don't. Now, I will say in our prospective study, we showed that pain scores were reduced for biopsy and drainage procedures, but we didn't really see that much of a benefit for venous access. So for metaports and placements and such, which was important for us because we actually trained a nurse practitioner. We're training him to place metaports, and he can't do the deep sedation on his own. So those patients will be totally fine with the moderate sedation still.
Okay, cool. And so then after the ketamine wears off for the patient, they're in recovery. Well, how long do you hold them in recovery after this? Is it the same as fentanyl Versed, just basically until sedation wears off, or are there different rules?
It's the same as moderate sedation. So it's until their sedation wears off, and it's about the same time as a moderate sedation. It doesn't really add recovery time. It's a very fast-acting agent, so it's fast on, fast off.
Mm-hmm. Very cool, very cool. Okay, have you had any surprises since starting this regimen for your patients, good or bad?
Yeah, I'll think there was one really cool thing that happened. I guess it was my partner's case. So there was a patient who had suffered from traumatic brain injury and was coming in for a tube exchange, and it was nonverbal, basically only spoke in sort of grunts. And after they administered the deep sedation, for the first time, she started speaking in full sentences.
What? That's wild.
I know. It was pretty crazy. So
okay.
I don't know what that means. It's just a single case, but that was pretty shocking.
Was it just during the time she had sedation, or did it keep going?
It only was when she was in the cable, I think. Once she was out of the cable, back to the monosyllables, unfortunately.
Okay.
Let's see. I would say, 80% of the time you achieve exactly what you want, which is patient is asleep, they don't speak, they don't move, they don't remember anything, they have a good experience. And then the other 20% of the time, the patients don't fully go to sleep and they remember things. In that 20%, I would say 15 out of the 20, they still have a good experience. And there are some people who kind of enjoy the experience, if you will.
Yeah.
And then I would say then the other 5%, there are occasions where the patient will sort of still do that thing where you get with moderate sedation with kind of saying ow or things like that. But the vast majority of those people don't remember anything afterwards. So even though it's kind of uncomfortable.
The Versed's on board, right? So they're not really, hopefully, God willing, that's probably if they did have they went down the bad K-hole or whatever.
Yes.
And like, hopefully the Versed will help with that part.
Yeah, and the ketamine, it also makes you forget too, or it's supposed to. So I think the two of them together hopefully lead to a lot of, not remembering. I think the other kind of neat surprise was the fact that the post-procedure pain scores, so like in recovery, if you ask the patient, those pain scores were lower too. So ketamine has been kind of a hot topic out there now in the treatment of chronic pain. So it has some like anti-pain use. And so I think that you get some of that benefit. And you see that in the surgical literature where patients who get, big surgeries, if they get ketamine during their case, they use less opiates after the surgery during, the recovery period. So that was a nice surprise too.
Seems like this is good for like procedures that like are an hour or less, right? More or less. Or do you use them for longer procedures too?
That's a very good question because remember the maximum dose is, something like 100 milligrams, which, you might eat that up if you give the PRN doses. So I've been thinking about, I do my uterine artery embolizations with anesthesia, but I've been I think that would be kind of a good procedure to switch to ketamine.
Gotcha, yeah.
And I think that like a uterine artery embolization is kind of the perfect length procedure. Like you just get to, that would be like the maximum kind of time. We've switched over all our biliary drainages, spine biopsies, and I've been, I haven't been brave enough to, but I think I should probably switch my ablations, many of my ablations over to.
Yeah.
But remember, you won't get a breath hold. So for anything, a procedure where you need a good breath hold, it's not a great agent to use.
Gotcha. Well, neat. Gosh. Okay, so we talked about how you like to do it. We talked about how you were introduced to it. We talked about kind of next step, the next procedures that you want to bring to the field for this. I'm sure you've talked about this with other IR doctors like around the country. Have you inspired anybody else to start using ketamine as their main sedative or deep sedation agent? Or have you not heard of anyone else trying it yet?
Well, hopefully I've inspired you now. No, I'm just kidding.
I'm sure other folks are really interested in bringing this to their practice. Yeah, have you talked to anybody else?
I would say a couple things. Number one, I know like one of my colleagues from Sloan Kettering, Juan Camacho, he works in Florida in private practice now, and they do it there. So that was kind of, for me, when my ER friend like told me that she used it, learning that there was another IR program like already kind of doing it, motivated me to go ahead and proceed. And, at this point in my career, I feel very strongly about it. I feel very strongly that IRs would love it and that their patients would all benefit. So I have started, writing grants, publishing papers, and trying to basically get the word out. And whenever I go to a meeting, kind of talking about it, we're going to have a session at SIR where we talk about it. And, so I don't know that I have changed anyone except for my partner, who was, as I told you, he was over 30 years in practice, and he was obviously reluctant. People get into things that they're comfortable with, but if you ask him, he would say it was a game changer. And it just, for me too, it reinvigorated my love for what I do, because now I can like do my job and not have those awful moments where patients have a bad experience.
Oh yeah. Yeah. And especially in your specific patient population with just like the opioid epidemic stuff. I mean, this is like just so much better for those folks, I feel like, based on what you're telling me. Okay, is there anything else that you think our audience should know about going down this path if they're interested?
I'd say the main strategy is going to be to find a colleague, a partner, an advocate. So for me, I think, you asked, was it just easy just to bring it on board? And I think the thing that made it easier was to find an ER physician and an anesthesia doctor who agreed that it would benefit the patients and helped us turn that into action. I think there's always incidences in our work where patients file complaints, like after procedures that they weren't, adequately sedated and they had a bad experience. And taking those events is also a good way to maybe motivate administration to kind of take a look at this and let's find a better way to take care of people. I mean, kind of taking a bad thing, but turning it into something for good for the rest of the patients that you're going to treat in the future.
I guess, did you have to do any extra training or, stuff to get you, to let you have privileges to give ketamine?
Yes, my institution had a policy about how you could achieve privileges in deep sedation. So we followed the policy, and that included them proctoring us on a few cases. You have to be ACLS certified, but I think most times IR physicians are already ACLS certified. Your unit has to monitor people properly and have dedicated procedural nursing to monitor the patient, and the nurse needs to be ACLS certified. So these are all things that are usually in place already because of moderate sedation. So that's not such a heavy lift. We also had to demonstrate a facility with putting in those little oral or nasal airways, not intubation, but the little trumpets or whatever that just in case they obstruct. So the anesthesia doctor proctored us on just doing that a couple times and proctored us on a couple of deep sedation cases, and that was that.
Oh man, yeah. Well, I mean, you're a very unique situation because you have a lot of collegiality within your community, your physician community, and the support of your colleagues to kind of be able to get this done. So that's super fantastic. Amy, thanks so much for being on the show today.
Thank you so much for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dawn,
Michael Barraza,
and Ali Baheti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew
and Judy Dela Cruz.
Thanks again for listening.